I now invite the session coordinators, Dr. Praveen Shenoy and Dr. Gopika P, to introduce the moderator and the panelist and to facilitate the release of Cancer Opinion Survey.
So we are nearing the fag end of our the conclave for the day. So this will be the last session, section 6 on sensible policies for cancer care. As we know, the growing burden of cancer in India demands not only an advanced medical interventions, but also sensible patient-centric policies that can guide a coordinated and equitable responses. Now with cancer incidence and mortality rising sharply, driven by aging population, lifestyle changes and environmental exposure, there is a pressing need for policies that are both scientifically grounded and as well as socially responsive. Hence, to discuss and deliberate, we have our moderator, actually two moderators, Dr. Boban and Dr. Aju Matthew, who will lead the session along with many eminent speakers who will pitch in with their valuable comments, focusing on what will be the certain sensible policies in cancer control and its care. So I invite Dr. Boban, who is a senior consultant medical oncologist with over 2 decades of experience, and he is also our secretary of Association of Medical and Pediatric Oncologists of Kerala. I also invite our moderator, Dr. Aju Matthew, who is a senior consultant medical oncologist. He is also consultant in Ernakulam Medical Center and MOSC Medical College. He is a director of Kerala Cancer Care. He specializes in personalized medicine and clinical trials. He is also committed to education, mentorship, and public health. He serves as a member of PALIM India, USA.
Now we invite the next session speakers, Dr. Hanish George. He is a committed head and neck surgical oncologist and microvascular reconstructive surgeon, currently serving as lead consultant for Project RIHAI and Deputy Medical Superintendent at Kachwa Christian Hospital, Uttar Pradesh. His multifaceted experience makes him a key advocate for delivering comprehensive cancer care in resource-limited settings. We will welcome you, sir. Now I invite Dr. Rijo M. John. Sir is a renowned health economist and professor with expertise in public health policy and economics of non-communicable disease. A warm welcome to you, sir. Now we invite the next speaker, Dr. Christopher Booth. Sir is a medical oncologist and health services researcher at Queen's University, Canada, where he holds the Canada Research Chair in a population cancer care and directs the Division of Cancer Care and Epidemiology. With a clinical focus on gastrointestinal cancers, his global research on access, quality, and value of cancer care has led to over 350 publications, key advisory roles with the WHO and India's National Cancer Grid, and the co-founding of the Common Sense Oncology Initiative. Welcoming you, sir. Sir will be joining online. And we welcome all the panelists on the stage. Now I invite the moderators to hand over.
Thank you, Praveen and Gopika. All of you who had received the brochure in the early phase of this conclave preparation, might have seen that this session, the last session, was planned in a totally different way. It was on the role of policymakers in cancer care. So for the last several months, we have been inviting, we have been closely associating with many of the policy people. They are either in the executive level or in the legislative level to be part of this event. But then when we realized that, okay, things are not that easy as far as conclave is concerned, that was an even more bigger challenge for us. The reason was that the priorities were totally different. I'm not saying, that priorities are totally different. I'm not here to make any controversy or anything like that, but that's the reality. We all know that we have all faced it in our personal life, in our professional life, in multiple ways. But then the effort that has been put, the whole purpose of this conclave is to have that communication between the clinical side and the government side. And then, unfortunately, we couldn't materialize that the expectation what we actually want. That's okay, but then we were happy that, okay, we had a very fruitful discussion right from morning, and the very fact that so many of you are still staying back at 5:30 p.m. For the final session, that itself shows that the effort that was put behind this conclave is a big success. So first of all, I'd like to thank you, each and every one of you, for staying back this long. But then the final program needs to be changed. So myself and Aju, we had discussed, and then we had to change the terminology of the last session. But then ultimately the purpose is that, okay, how we wanted to bring in the people who have actually made the influence, how small initiatives have actually made big impact in the day-to-day clinical practice. So as part of all of you, by this time must be aware that as part of the cancer conclave, we did this cancer awareness in the state. It's a small study, but then it was validated in the proper way. And I'm not an expert in all these things. Haju has been doing the study. AMBOC has been funding. I've been mentioning in the morning also, AMBOC is a very small association, but then we have done this small, newer initiatives, everything has been done. So as part of this Kerala Cancer Conclave, we are releasing this cancer awareness, and I feel like I was supposed to present, but I feel it's not me, but Aju is a better person to present because everything is, he knows everything. I will be only able to read it by heart, but Aju will be able to speak from heart. So I request Aju to take out the proceedings to release the Kerala Cancer Awareness data.
Thank you. Thank you, Boban. So this session is all about sensible policy making. And just before we talk about policy making, we need to know what is currently existing in the state of Kerala in terms of the awareness. So the first part of this session, which is going to be a brief session, I'll discuss the findings of our cancer awareness survey, which is the first and the largest survey of a similar proportion done in India, published in eCancer journal simultaneously and peer-reviewed as well. After that, Dr. Hanish George will talk about his experience working as a head and neck surgeon in rural Uttar Pradesh, following which Dr. Rijo John, a health economist well known all over the world, will talk about taxation as a policy instrument to change behavior. And finally, we have Dr. Chris Booth coming online to share his findings from the large trial which he initiated as a fellow in 2009, which was presented at ASCO and published in New England Journal about exercise. And we need to discuss how we can promote exercise for our patients as well as for the general public. So briefly, the findings of the survey. I'll just rush through the slides. These were about 2,500 respondents from across the state of Kerala, 60% of whom resided in a panchayat, 17% resided in a corporation, and 20% in a municipality. The age demographics represented the aging demographic pyramid of Kerala. About 10% of respondents were above 65 years of age. Bulk of our respondents were in the middle age category. 63% were women, and classic for Kerala, only about 1 or 2% had no formal education. Rest everybody were highly educated. So what did we find? 90% of our respondents claimed they knew something about cancer, and 80% of them, of our public, expressed that they were very confident in understanding early signs of cancer. Now, 80% of our public also expressed concern about their personal risk of developing cancer at some point of their lifetime. So, people are concerned. And interestingly, around 60% of our public were able to identify lifestyle as a risk factor. 60%. That means we have scope for improvement. 40% still do not know that lifestyle is a contributory factor. Only 3% entirely dismissed connection between lifestyle and cancer. 90% of our public are aware that smoking is bad, but only 70% of our public are aware that alcohol is bad. Bad diet, 60% of our public are aware that bad diet is bad. Trans fat, 50% of our public has heard something about trans fat. And around 1/3 of our public know that environmental pollution has a link with cancer. But interestingly, we just tricked the public to two questions. We asked if they thought pesticide use, safe pesticide use causes cancer, and around 25% of patients or public said they think that even safe pesticide use causes cancer. We also asked them a question, do you think mobile phone use can cause cancer? And nearly 1/5 of our public strongly believes that mobile phone use can cause cancer. So there are some myths in our community. So again, 87% thought that smoking is a risk factor. Only 73% thought that alcohol is a risk factor. We then asked our public whether they thought sports persons and film actors smoking on screen, is that a bad precedent? And only 11% said that it's okay, let them smoke. Rest of them either were unsure, but were saying that it actually creates a bad impact on our society. So I think as professional bodies, one thing we can do is to raise awareness and lobby with our sports persons as well as our influential film actors to avoid on-screen representation of bad lifestyle choices as well as advertisements. Only 20% of our public have gone through some sort of cancer screening. Now, these are not investigations, but maybe a clinical breast exam could count as some form of screening. It is not mammography, but 1/5 have undergone some sort of cancer screening. 73% of our public are concerned about cost of care. 50% of our public are concerned about side effects of therapy. And like I said earlier, only 3% of our public feel that only alternative medicine can cure cancer. Vast majority of our public believe that conventional treatment is necessary, but nearly 38% of our public want both us, oncologists, as well as alternative therapy physicians to take care of their cancer, which means there is some messaging that still needs to be communicated. Only 15% of our respondents believe that vaccines prevent cancer. So in this time and era, HPV vaccine is widely available. There is some scope for improvement. And only 1/3 of our public were aware that genetic testing can sometimes help with cancer risk reduction or prevention. Interestingly, only 15% of our public feel that cancer is fatal. That is good news. Vast majority of our public feel that cancer is not fatal, especially if it depends on the stage. Is there stigma associated with cancer? 66 said no, 14 said unsure, but 1/5 of our public still believe that there is a stigma associated with cancer. 70% of our public said they get their health information from doctors. 30% said they get the health information from the family or through social network. 70% turn to social media for their information, and very few turn to TV and radio for their health information. Finally, we mirrored a survey with a similar survey done by American Society of Clinical Oncology, so we could compare the results. When you compare the ASCO survey in Kerala, 80% expressed concern about future risk, whereas 50% in America expressed concern for future risk. 90% of Malayalis thought that lifestyle is a risk factor, whereas in the US only 30% believe that lifestyle is a risk factor. So overall, we are doing a good job in terms of communication. If you come to alcohol, 70% of our public believe that alcohol is a risk factor, whereas in the US, 35% linked alcohol to cancer. The only concern for the US here is 35% believe that cancer can be solely cured through alternative therapy. So we identified some gaps. We felt that our public is well aware. Awareness level is quite high. But there is some limited awareness on some factors like HPV vaccination. We identified low screening rates, and we identified that cost of care is still a big concern, and there are some misconceptions as well. So our recommendations from AMPOC is that we conduct tailored educational interventions. We tried our best to enhance screening access, address financial barriers, and also highlight our findings in global scale, which is why we will have our conference proceedings submitted and provisionally accepted to an American Journal of Clinical Oncology after this, so that there could be bidirectional learning from our experience of doing good communication on risk factors to a Western environment where they are not doing up to the speed in terms of education. So I'll stop here and I'll invite Dr. Hanish Josh to discuss about tobacco as a risk factor in the place where he practices.
A very warm good evening. First of all, I'd like to thank God and Dr. Aju for this opportunity that has been given to me. I consider it as a privilege and an honor to be here and share to you some of the experiences that I have personally faced in the last couple of years. Dr. M.R. Rajagopal was here this morning with us, and he was one of the pioneers, sir was one of the pioneers who actually introduced me to pain and palliative care back in 2016. And that's the first time we started the service in a rural healthcare setup in the district of Mirzapur in Uttar Pradesh. We have been hearing about various statistics across Kerala and across most of India. And it is very, very encouraging to see, the numbers of how people are aware of the various things. In fact, something on a contrast, I have to present from the state of Uttar Pradesh. So the data from 2023 says that 33% of all cancers in Uttar Pradesh is actually head and neck cancers, which is quite a drastic difference from what we heard this morning. And next comes breast and then cervical cancers. So there are roughly around 2 lakh new cancers that's diagnosed every year in the state of Uttar Pradesh alone, and out of which 33% is oral plus head and neck cancers. So this is a big contrast. Now we all know the various stages. Now some of the next pictures might be a little gory. Please forgive me for that. So most of the patients who come to us, I would say only 20% of the patients who've come to us have come in stage 1 and stage 2, which we consider that, is relatively has better prognosis and better treatment outcomes. So these are 2 such patients. Now this is another patient who came to me with the picture on the left, this picture on the left. He came to me after being diagnosed from government sector, and sadly he spent around 4 lakhs from his personal and some insurance based things like the government schemes, and what he received was he showed me his previous pictures. I don't have it right now, but a very small lesion which was given, he was given multiple rounds of chemotherapy, and he was given antibiotics, and he was denied treatment for 6 months later on, and then he presented to us with this picture. Now we told him that this is something that is really advanced, but he comes with a picture of, he looks old, he is just 34, a wife, 4 kids. He really literally begged, and he said that if there is anything at all that you can do to preserve my life for another at least 1 year, please help us out. He understands, the outcome may not be that great. With all considerations, we went ahead, and the surgery went on, and by God's grace, he's keeping okay at this point in time. But, the lack of awareness. Same, this another patient on the left, we can see a huge defect. Similarly, this patient on the right, he underwent a surgery elsewhere, spent almost 4 to 5 lakh rupees. In months' time, now he's lost everything, and he's been shut out from his previous center because he doesn't have any more money for any treatment. He's come with a local recurrence. And now this elderly, I would call a Baba, like how we call it up north, he came with this big proliferative mass. I saw him, I don't have the previous picture, I saw him a couple of months ago. He was quite fit for surgery, but the family and he himself was not very keen on surgery. So from a medical standpoint, I thought, okay, if he's not fit for surgery, then we can put him on oral metronomic chemotherapy or palliative chemotherapy. And to my understanding, perhaps I didn't think that he would there would be any difference in his lesion or disease. 4 months into the therapy, to my surprise, this is what we saw. And this is yet another man, this tumor you see here. He came to me 4 months ago, and with a small lesion, advised surgery, never came back. 2 weeks ago he called me, he said, his son called me and said, he sent me a video, profuse bleeding, and just in a sad state, he's like, I'm about to die, help us out. And the sad part, after all this, the patient is in the ICU. I wanted to go and meet the children and the wife, and then I see that the wife is sitting and chewing tobacco, both the sons are sitting and chewing tobacco. That's a sad ground reality. This is from 1 week ago. And this, I mean, you may feel that this man is, quite old, and, he's actually just as old as me. He's just 32. there's perhaps nothing that I can offer from a curative point of view because, this big fungating mass that is sitting right under the skull base, I can see, the underneath of the brain from the oral cavity. So, and this young man, again, he looks so devastated, he looks so poor, but he waited for government funds to come for 6 months, and he never received any therapy, and this end-of-life care was given to him. So I would like to draw some points out of these grassroots realities. We saw fantastic statistics across the state of Kerala. I'm a proud Malayali, I can say. I'm very happy about everything that's being done here. But there's a huge contrast in the things that we see here and up there in north, especially when you go to a rural setup. Lack of awareness about the ill effects of tobacco, especially chewing tobacco, is so prevalent that almost 70% of the population, they chew it out of habit. You come to Varanasi, the first thing that they'll give you is pan. They'll say, oh, it's meetha pan, like sugared pan. It does not cause any trouble. But it'll be flavored with everything else inside. They're not aware. They'll be using all forms of toothpaste, all forms of various tobacco products, but they're not aware. Whereas in Kerala, 20 to 30% are the only people who are not aware that this can also cause cancer. And rampant abuse. We did a study among school population. It's not published, but we have the data where we know that also based on GYTS, the Global Young Tobacco Survey, the national percentage is 14% of the students, school-going students in the high school start the abuse of tobacco. But in Uttar Pradesh, the percentage is 23%, much higher than the national standard. And other reason why these people are so addicted to tobacco is because, the daily wage that they get is so low and they have to keep working, like real strenuous work. And I asked them, why do you have to do it? We can quit your habit. They're like, for us to do this hard labor, we need something that gives us that kick so that, at the end of the day, we get something, 200, 300 rupees so that, our family would survive. So it's a vicious cycle. And there's so much myth and there's so much stigma around, you do a biopsy, 90% of the population believes that, oh, if you do a biopsy, it's going to spread for sure. And that's the reason 80%, more than 80% of the patients who come to us come only in stage 3 and stage 4. And I must admit, this is not to, pull arrows or strings at anyone, but highly prevalent unethical work up in rural North India. So that's something that has been a major reason because of which there is a delay of almost 4 to 6 months from the diagnosis to treatment. And very few government centers, when we look up to the data for UP, there are only roughly around 8 to 9 government centers for greater than 2 lakh new cancer cases per year. So the waiting list is almost 3 to 5 months. And poor access to private centers. I was looking at what is the expendable income that a person in Kerala can have. That's like 3,000 to 6,000 rupees. In UP, that's like 500 rupees. So that's the ground reality. A lot of us know about tobacco. People are aware, but up there, the situation is entirely different. How can we bring a change in this? That's what I want to leave you with. Thank you.
Thank you, Hanish. So the reason we've had Dr. Hanish, who's done a tremendous job in rural Uttar Pradesh, is primarily because it's not that people aren't completely unaware about tobacco's bad effects. So they know about it. What else can we do? And that is where I wanted to bring in our expert, a health economist, who's written extensively on tobacco as well as alcohol. His recent paper was in New England Journal on alcohol, on whether taxation can be an effective policy tool in curtailing risk factors. The slides are going on its own. Can be an effective policy tool. Dr. Riju.
Thank you, Ajju. Thank you for inviting me here. I understand that I'm the last speaker standing between today's session and your evening, so I won't take much time. Actually, the previous session, the discussion was about increasing, how the healthcare or the cancer care is becoming increasingly less affordable, right? And we have no doubt that everybody agrees that the cancer care needs to be made more affordable to people. But I'll tell you what is becoming actually more affordable over the last 10 years if you look at the data. Products like tobacco, like be it cigarettes, BDs, smokeless tobacco, sugar-sweetened beverages, alcohol. All these products have become affordable over the last 10 years. And I'm just not, this is not just random talking, this is based on published research. In the last 10 years, when I mean affordable, I'm talking about the percentage of your income that is required to purchase a fixed amount of this product has decreased in the last 10 years. For example, like let's say 10 years ago, if you were to spend say 2% of your income to purchase say 100 sticks of cigarette, today you have to spend much less proportion of your income to purchase the same amount of cigarettes, right? So that is how these products are becoming increasingly affordable. And that is where the taxation as a policy instrument becomes very important. Bodies like International Agency for Research on Cancer has clearly pointed out that there is sufficient evidence to show that increasing price leads to a reduction in consumption. There's a lot of people who ask questions on like, it is an addictive, tobacco is addictive, alcohol consumption is addictive, and how can a tax policy really decrease consumption? This is a common question that people have. But, there may be a small section of people who are not price sensitive, who may not really reduce the consumption because the price has gone up. But we are talking about population level intervention. When you're talking about taxation as a policy instrument, it is a population level intervention, wherein on average, we see that people are price responsive or price sensitive towards these products. This is simple economics. When the price increases, there are people who are more price sensitive and less price sensitive. People from the lower income group are generally more price responsive or price sensitive. People who are young population are more price sensitive. When we talk about products like tobacco, price sensitive, it is good that the young population who are initiating smoking are more price sensitive. Tobacco smoking is known to be more prevalent among lower income communities who are again more price sensitive. So clearly there is evidence from around the world from multiple data sources which shows that there is a negative relationship between price and consumption of these products. We have data from India which actually estimates using, we have household consumption expenditure survey where the government of India, it's a nationwide representative survey wherein it looks at the consumption patterns of Indian households. And through this survey, it is possible to estimate how people respond to prices of different products. And we estimate that, the price, in economics, we use the term what is called a price elasticity of demand. It is basically the percentage decrease in consumption in response to a given percentage increase in price. So let's say there is we see that the price elasticity for cigarettes is something like 0.5, which means a 10% increase in price of cigarette would result in a 5% decline in the consumption of cigarettes. The price response or price elasticity for BDs is 0.8, so it is more price sensitive. BD smokers are a little bit more price sensitive than cigarette smokers, right? So similarly, we have price elasticity estimates for all these products like alcohol, sugar, sweetened beverages. They are all price sensitive. That is the bottom line. So the idea is that increase in price would result in a reduced consumption. And reduction in consumption comes not only from the reduction in the quantity of consumption, but also the reduction in the number of people who are initiating the consumption and also the people who are quitting the existing consumption. This all happens. Now, with that set aside, that the price is an important factor, how can the price be increased? Of course, taxation becomes one important tool. The WHO has categorically stated that among various tools out there, instruments out, the public policy instruments out there to regulate the consumption of this product, taxation remains the most cost-effective tool for regulating the consumption of these products. And this is also the reason why the tobacco industry and the industry in general is more concerned about tax increases than any other policy interventions to control these products. So they lobby big time, the government, to prevent any kind of tax increases on these products. So there's also a lot of conflict of interest here. You know, the government of India owns more than 20% of the ITC's shares through its own public sector undertakings, through insurance companies. So there is such conflict of interest, and the industry lobbies very hard to not initiate any kind of tax increases. Unfortunately, in India, we right now have a system called GST, Goods and Services Taxation, which was implemented in 2017. Up till 2017, the taxation of these products used to be controlled by both the central government and the state government. We had an excise duty imposed by the Union Government of India, which was same across the country for all the for a given product. Whereas we had each state government having their own value-added taxes applied on different tobacco products, right? But with the introduction of the GST, all these excise duties and VAT, they all came together in the form of a single tax called GST, Goods and Services Tax. So basically the states surrendered their right to change any taxes on these products. So what used to happen before the introduction of the GST is that every year during the annual union budget, you would see the finance minister declaring that the tax on cigarette has been increased by 10%, the excise duty has been increased by 10% or 15%. Many state governments in their own budgets used to make changes or increases on VAT applied on different tobacco products. But that no longer exists now. That doesn't happen anymore. Ever since the introduction of the GST, it's been 8 years. Now we are, July 1st, we'll be completing 8 years of GST. In the last 8 years of GST being in place, we had zero increase in taxes, increase in taxation of tobacco products, zero. There hasn't been any increase of tax applied on these products, and that is one of the reasons why these products have become more and more affordable. There has been 3 or 4 different studies published in the international journals in the last couple of years, all of them pointing out the increasing affordability of these products. So it's very important that the taxation as a policy instrument which has been tried and tested across the countries has to be utilized in a more efficient manner. In fact, WHO recommends that the taxes should constitute at least 75% of the total retail price of a tobacco product. That is the recommendation by the WHO. Whereas in India at the moment, the tax burden, the tax as a percentage of the retail price is what we call as a tax burden, is much less than this 75%. It is close to 50% for cigarettes and around 60% for smokeless tobacco, only 22% for BDs. What is interesting here in India is that, if you look at the tobacco consumption pattern in the country, majority of the tobacco consumption happens in non-cigarette forms, right? For every single cigarette that is smoked, there is 4 to 5 BD sticks that are smoked, right? And smokeless tobacco use also is extremely high. So cigarette smoking as a proportion is very small. Yet, almost 85% of the tax revenue generated from tobacco use or tobacco products comes from cigarettes alone. So there's a huge discrepancy in taxing these products. You're not really taxing. Taxation is really not being used as an instrument to regulate the consumption here. They are being used, or they have been looked upon as an instrument to generate revenue, not really used as an instrument to regulate the consumption. So that needs to change. If that has to be changed, it means that the taxation on products like BDs has to be brought up on par with the taxation on cigarettes. There is no public health rationale to keep the taxes on BDs at much lower rate compared to cigarettes, because BD is as harmful as cigarettes. So there is no reason for its tax to be lower, right? But of course, there is a huge BD lobby every time there is a talk about increasing taxes on BDs. there's this huge lobby that comes into action, and that doesn't happen. In fact, under the GST, fortunately, there is a standard 28% GST that is applied on all tobacco products, including BDs and cigarettes, but there ends the similarity. Apart from GST, there is also something called a compensation cess, which is applied on certain products like, demerit products like tobacco, sugar-sweetened beverages, and some luxury goods, etc. BD is the only tobacco products on which there is no compensation cess. And this compensation cess component itself constitute more than 50% of the overall taxes applied on these products. So it's very important that these taxes are equally applied on all these products, but that is not happening yet. And unfortunately, this compensation cess itself, which constitutes the major component of this overall tax, is coming to an end as of 31st of March next year. So that will have to be replaced by something else, and we have been proposing for replacing it with something called a dedicated health tax to be applied on all these demerit products or unhealthy products. So this has been one of our recommendations as well. So the idea is that taxation should be used, or it should be used as an effective tool to make these products less and less affordable over time so that its consumption is reduced. Between the two global adult tobacco surveys that was done in India from 2001 to 2007, 2011 and 2017, we have two rounds of global adult tobacco survey. We have seen about a 17% relative reduction in the prevalence of tobacco use in the country. So it is not that the tobacco is like completely addictive and people don't quit tobacco use, but that's not the case. We are seeing reductions in prevalence, and that during that time was also a period where we have seen consistent increases in taxation of these products. I'm not saying taxation was the only reason why we saw a reduction in prevalence. There are other non-fiscal measures that were also in place. But post-2017, from the introduction of the GST, as I was mentioning already, there hasn't been any tax increases. It has made the tobacco products more affordable. And I wouldn't be surprised to see if in the next round of global adult tobacco survey, we might even reverse some of the gains in reductions that we've observed in the past. When it comes to all these risk factor products like, BDs, cigarettes, tobacco, alcohol, sugar-sweetened beverages, alcohol is the only product for which a taxation power rests with the state governments. In Kerala, the taxation on alcohol is actually quite high. It's about 85% of the retail price of alcohol is taxes constitute about 85% of the retail price. But then, for the government of Kerala, this alcohol tax revenue is a major revenue source. More than 25% of the state's own tax revenue is generated from alcohol taxes, right? Because this is a huge tax earner for the government, it is also in the interest of the government to keep the alcohol consumption high, right? There's no incentive for it to reduce the consumption because it is a huge revenue yielder for the government, right? And that needs to change because governments needs to understand that, increased consumption of these products are also costing a lot of public health money. I mean, there's this huge public health cost from the consumption of these products. And the government is contributing towards public health. So the more people consume this product, it means there's more public health spending that will be required, right? So that needs to be changed. So the reliance on alcohol tax or tobacco tax as a source of revenue, that attitude needs to change. We have to be able to use the tax as an instrument to regulate the consumption and eventually reduce the consumption of these products. So I'll stop with that. Thank you for listening to me, and thank you.
Thank you, Dr. Rijo, for this very nice, short but very illuminating talk on taxation as a policy tool. Now I'll segue to Dr. Chris Booth with his exercise study as well as his ideas on exercise and physical activity. This session, Chris, is about sensible policy making to mitigate cancer risk. What can you tell us about this particular topic of interest of yours? Over to you. You're on mute, Chris.
I'm
now it's
not
on.
on mute. Can you
No,
hear
no,
me
it's
now?
fine. Now it's fine. Thank you.
Great. Thank you, Dr. Adju and colleagues, for inviting me. I have a few slides that I'll share just to show some of the data about exercise that leads into some of the policy discussions. Great. Adju, can you see those on the screen?
Yeah, yes.
That's great. So thanks. I think as we've heard in the earlier sessions about using our health system resources in a way that can maximize the individual and public health benefit. So the story of exercisumab is something that, as Dr. Matthew commented on, I've been working on for well over a decade. And so this is a paper that was published in the New England Journal of Medicine a few weeks ago after we presented it at ASCO. And it started with an observation that lifestyle may have a role in protecting cancer recurrence. And so there was early observational data, both in breast cancer and colon cancer. But as we know in observational data, there's limitations, and patients who exercise might be different in other ways from those who do not. And so for that reason, we launched the challenge trial many years ago to answer this question using a randomized design. So very briefly, patients with colon cancer who had completed surgery and adjuvant chemotherapy underwent baseline fitness testing and were then randomized. It was a very pragmatic design. The control arm patients received an educational booklet encouraging healthy lifestyle and exercise. The intervention patients received a funded personal trainer, exercise specialist, for 3 years to help them increase their exercise using behavior change techniques. And this was developed using theory of behavior change. The exercise specialist met with the patient every 2 weeks for the first year, and then once a month for year 2 and year 3, and came up with an exercise prescription allowing their own lifestyle, whether it was walking, biking, swimming, running, or yoga, to allow them to achieve their exercise targets. We enrolled 900 patients over 15 years from 6 countries around the world. Most patients, however, came from Canada and Australia. The patients represented a fairly typical clinical trial population of stage 3 colon cancer patients. They received the usual chemotherapy regimens, and there was no important difference between the arms and baseline characteristics. The adherence to the mandatory coaching and exercise sessions, again, the exercise specialist would meet every 2 weeks to provide motivation, goal setting, time management, and exercise goals. The adherence in the first 6 months was 83%, 68% in the second 6 months, and during year 2 and year 3, it was 63%. The only safety or toxicity signal which emerged was a slight increase in the risk of musculoskeletal injuries in the exercise arm. As shown on this slide, the exercise program led to substantial and sustained improvements in self-reported exercise levels, as well as physiologic measures of fitness, including improvements in VO2 max, 6-minute walk test, and the patient-reported outcome of primary interest, the physical function subscale, was also improved and sustained over time. The real excitement, however, relates to our primary endpoint, disease-free survival, in which there was a clinically meaningful and very significant reduction in the risk of recurrent or new cancer. Disease-free survival at 5 years was 74% in the control group and 80% in the exercise arm. This translates to a number needed to treat. For every 16 people who go on the exercise program, exercise prevented 1 person from developing recurrent or new cancer. When you look at the DFS events that were observed in this trial, there's a few important findings. First of all, exercise led to a reduction of distant metastatic disease, largely in the liver, but there was also a very strong signal that it reduces new primary colorectal cancers, and an intriguing hint that it reduces other cancers, including breast and prostate cancer as well. Of course, those data are exploratory and were not the primary objective of the study. There was also a clinically significant and statistically significant reduction in the risk of death. This trial had very mature follow-up with a median follow-up of 8 years. When we looked at overall survival at 8 years, it was 83% in the control group and 90% in the exercise arm. meaning that for every 14 people who go on this structured exercise program, exercise prevented one person from dying. So very briefly, the conclusions are that we think that the challenge trial establishes a new standard of care and that an exercise program has clear benefits in fitness, patient-reported outcomes, disease-free survival, and overall survival. Notably, the magnitude of benefit, the hazard ratio, and the number needed to treat is very favorable. In fact, it's comparable and even exceeds some of our standard medical therapies. These data tell us that exercise is no longer just a fitness or quality of life intervention. It can be conceptualized as part of a treatment program for colon cancer patients, and this leads to the policy discussion of the session today, how we can implement this into standard of care. Because knowledge alone, oncologists just telling their patients to exercise will not be sufficient to change patient behavior in itself. In fact, that essentially was the control arm of the challenge trial. We need health systems, hospitals, and payers to invest in this behavior support program to allow patients to increase their exercise over the first 6 months and then sustain this change in lifestyle over the subsequent 3 years. And I guess the last comment I'll make from a policy perspective is that although our formal cost effectiveness analysis is still underway, this is very likely to be highly affordable for health systems. It is estimated that the total cost of an exercisumab intervention is approximately $5,000 in the Canadian context over 3 years. And of course, compared to the very expensive price tag associated with many of our new cancer therapies, this is likely to be very sustainable for health systems. So thank you, Dr. Adju, for allowing me to share those thoughts. I'm happy to engage in any discussion subsequent.
Thank you, Chris. I'll open the floor for comments and questions. But before that, exercisumab sounds very fancy. Unlike drug trials, when they are published, where I just blindly believe the results, I must admit, when the exercisumab trial came out, I was keenly watching out for design flaws because I couldn't just believe it. But anyway, sounds like it is a reliable trial because the on-target toxicity, the MSK adverse events is higher in the group, so there is some on-target toxicity. But who will pay for it in Canada, for instance? If you find that this is cost-effective, what do you do next as a health systems researcher, as a policymaker, influential person there? What is the next step for a Western society?
It's a great question, Aju. So, my vision is that, we have a health system, at least in Canada and most parts of the world, where the system or the Ministry of Health pays for someone to have surgery for their colon cancer. That patient then sees myself as an oncologist, and the system pays for the chemotherapy. And I would like to see a model where when they finish their adjuvant chemotherapy with me, I can refer them to an exercise specialist in the hospital or the cancer center that will then deliver this intervention over the next 3 years. In the Canadian cancer system, we have precedent for that. We have the system funds social workers, dietitians, and speech-language pathologists in our cancer system. So I don't think it's a stretch to include exercise in that space. There's been tremendous interest in this because the risk-benefit ratio of this intervention is really remarkable, because even if someone doesn't derive a survival benefit from their cancer from exercise, clearly they're going to feel better, have improvements in quality of life, fitness, mental health, etc. And the Ministry of Health has been very interested in this. So within a few days of presenting this paper at ASCO, we had meetings with the leaders of the Ontario health system who have expressed strong interest in moving this forward. Again, I think in many ways systems cannot afford not to do this, because the cost of inaction with an increasing rate of both primary cancers as well as recurrences both has a tremendous human toll for our patients and their families, but also a very high price tag for the health system. So there's interest in moving it forward, but as you say, there's a pathway for approval and funding of drugs that's actually quite straightforward. So there's a bit of a paradox here. A treatment that has low toxicity and low cost, but very high benefit, might actually be more difficult to implement, but there's certainly a momentum and movement both in Canada and other health systems around the world to make this happen.
Dr. Pramesh has a comment or a question.
Yeah, thanks, Chris. That was a great talk. And Chris didn't mention this out of modesty, but this received a standing ovation at the ASCO annual meeting. And in fact, the ASCO Scientific Program Committee was heavily criticized that this did not feature in the plenary, where probably less impactful studies were actually presented. Coming back to the 4 excellent talks that we've had. I think as physicians, we are more geared to look at newer treatments, newer interventions to improve outcomes, but I think the 4 talks clearly showed that we need to think much beyond all of these. And the examples that came out about tobacco control were, in fact, extremely useful. And behavior change, as Chris mentioned as well, is extremely difficult. If you tell the 100 people sitting in this hall to start exercising tomorrow, it's likely that most of them wouldn't end up doing that, which is why we need nudges like the taxation, reducing tobacco use. And it's been clearly shown that if you triple the cost of tobacco, you have the actual consumption of tobacco, but also double the income for the government. And this has been a strategy that's worked very well in several other countries, and I think it's about time that we advocate for something like this in India as well. The exercise problem is also something that can be nudged, just like taxation is used as a mechanism for tobacco use. Some of the insurance companies now in India actually link your Google Fit or your Fitbit to your premium discounts. So if you cross an average of more than 10,000 steps every day on your Fitbit, you get a 5 to 10% discount on your next year's health insurance premium. And I think these are the nudges that we need to give as part of policy advocacy that will actually promote healthier lifestyles overall. But 4 great talks.
Thank you, Dr. Ramesh. Dr. Mohini sir, do you have any comments on this topic? This is your interest too.
No, I just want to point out same thing that if you ask them to people to take a pill to prevent, they rather take that rather than behavioral change like smoking or exercise. So it's a steep hill to climb. I really admire Dr. Booth's work, but implementation in a population-wide level, we physicians need to nudge them rather than developing a system to make a change.
Thank you. Any other questions, comments? Thank you. End of the session, and over to Secretary to conclude the day's proceedings. Thank you, Dr. Rijo, for your wonderful talk. Dr. Booth, thank you for joining us from Kingston, Ontario, early morning. And
Thank you.
Dr. Hanish from Kachwa, Uttar Pradesh.